Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion chronic kidney disease. So all are aware about that. Already we started the genitourinary emergencies. So last presentation we dealt about the acute kidney injury. So following that we are going to discuss regarding the chronic kidney disease. So this is what our today's talk regarding our introduction to CKD. What are the various causes and then risk factors, how it is working on a pathophysiology, and then calculation of estimated glomerular filtration rate. Based on this, we will group the person into various stages and clinical manifestation, how we are diagnosing, and then assessment point in both pre-hospital and then in-hospital. Finally, we will end up with the management and complication. So this is what our definition of chronic kidney disease. So first we'll divide the term. First, what is mean by chronic? So chronic is a general term. So when if the disease or condition that is persist or present 3 or more than 3 months means that is called the chronic. Okay. So if any condition or disease that will persist or present 3 or more than 3 months means that is called the chronic. Okay, if you are applying this concept into our renal system means, so the renal decreased renal function or kidney damage that will present 3 or more than 3 months, that is called the chronic kidney disease. Okay, the term is very simple, remember that 3 or more than 3 months, that is called the chronic. If the kidney damage or the decreased renal function that is presenting more than 3 months or 3 months means that is called a chronic kidney disease. Okay, so the coming into chronic kidney disease, so kidney functions means decreased kidney function means what are the kidney functions, already we discussed in the AK itself. So it mainly it will take participate in the, it will remove the waste product from the body. Second thing, it will take part in the water homeostasis, and then it will maintain the electrolyte level. It will secrete, fourth function, it will secrete some proteins and then hormones. That proteins like erythropoietin that will take a role in the your hemoglobin production, and then we told some hormones also the kidney will secrete that will take part in your systemic regulation, blood pressure regulation. So those are the various function that, so whenever the person getting into AK or CKD, these are the function will disturb. Okay, so this is what the CKD definition. How we can correlate with AKI with the CKD? So correlation between the AKI and CKD. So AKI we told that will develop more sudden, that is a abrupt development, or it will develop more suddenly. So the sudden kidney dysfunction or that function of the kidney will reduce suddenly. Okay, but CKD that will take a time. It will take, we told 3 or more months, like it will persist 3 or more months. So in AKI, if you are treating the cause means it will resolve or it is a reversible one, but CKD is a irreversible one. Okay, so these are the some common uh, uh, distinguishing factor or differentiation between the AK and CKD. Okay, so when the person will approach us, so if you are dealing with a pre-hospital means, so usually CKD we can diagnose in a person with CKD in a two common ways. First one, the person they will go for the regular checkup. In that regular checkup, they will find out or they will rule out the CKD. Means if the person have an increased creatinine level persistently means, or some other complications persistently that present means, through the regular checkup they will find out the person have a CKD. That is the one way. In another way, in other hand, how we are diagnosing it, the person will approach the emergency medicine department or EMT paramedic with a history of or with the complaints of cardiac arrest. So that is one of the things. Some life-threatening in emergencies like arrhythmias, palpitation, or some person they will present with this with the complaints of oliguria, anuria. Those are the some common regarding life-threatening emergencies. With the complaint of life-threatening emergencies, they will approach us. So we will treat something, and then if we are handing over into a definitive care, they will go through some of the investigation. By that, they will find out the CKD. So these are the two common ways. First way, through the regular checkup, they will find out, they will identify the person have a CKD. In a second step, the person present with us with the history of some with the complaints of some life-threatening emergency. So as like I told, anuria, or oliguria, or some of the person they will approach us with complaints of cardiac arrest, and then we will deal some cases regarding the hyperkalemia related things, arrhythmia. So those are the common ways, two ways will identify the CKD. So what are the causes for the CKD? First one, congenital, by birth, from the birth. First one is a obstructive uropathy. So it is a obstructive uropathy, congenital obstructive uropathy is a one of the major main cause for the CKD in the children. In a children population, CKD, if the person, if the baby have a CKD means, so obstructive uropathy we have to rule out. That is one of the major important cause in the CKD in the children. And then second most common is a polycystic kidney disease. Poly means we know that is many, okay, many or more. Cystic means, so it is a fluid filled lesion, or fluid filled, some bulge like a thing, fluid filled lesion. So if many fluid filled lesion present in and around the kidney means, that is called the polycystic kidney disease. So if the lesion present inside the medulla or inside the kidney means, that is called the medullary cystic kidney disease. And then this is what the congenital. Coming into glomerular part, so this is primary and then secondary glomerular nephritis. Glomerular nephritis is nothing but itis means inflammation. If any inflammation or damage that occur in the glomerular compartment, that is called the primary glomerular nephritis. So primary means, so the injury or damage directly that will occur in the glomeruli. So there is no any indirect mechanism, directly whatever toxins or some other thing that they will attack directly glomeruli. Secondary means because of some disease like diabetic hypertension, systemic lupus erythematosus, because of the disease complication that will affect the glomerular, thereby it leads to the secondary glomerular nephritis, that is called the secondary glomerular nephritis. And then third part we are going to see about the vascular. So if any narrowing of the renal artery is there means, that is called the renal artery stenosis or hypertensive nephrosclerosis. Sclerosis means what? Sclerosis means, so that soft structure will become a hardened, okay, that will become a more hardened. So that is called the sclerosis. If the kidney gets hardened, gets hardened means, that is called the nephrosclerosis. Here we are not only indicating the kidney, that might be the various structures like glomeruli also it can affect, or it can affect your blood vessel also, it can affect nephron also, it can affect. So nephrosclerosis in the sense that include all the structures of your kidney. So because of the hypertension, the vessels are your glomeruli or nephrons or your kidney getting hardened means, that is called a hypertensive nephrosclerosis. Renovascular disease, vasculitis also one of the common causes. And then fourth part is a tubulointerstitial nephritis. Here idiopathic drugs like a non-steroid anti-inflammatory drug and then some immune mediated can occur. Renal papillary necrosis also some of the common causes for the CKD. And then final part, fifth one is a urinary tract obstruction. So again, whenever we are hearing obstruction, we have to think about the two things, that is intraluminal and then extraluminal. So urinary tract obstruction, intraluminal means there will be some abscess, or abscess is a rare one, but there is some stenosis or any tumors, intraluminal tumors or any extraluminal tumors or any stone presentation inside the lumen. Those are the some common causes for the urinary obstruction, thereby it leads to the CKD. So risk factors, diabetic mellitus, hypertension, some cardiovascular disease, acute kidney injury if we are not treating, or even though if we are treating also it can lead to the CKD. Malignancy is a common thing, congenital history, kidney stones, infection like HIV and then hepatitis C, autoimmune disease, nephrotoxin and then NSAIDs. So what is the pathophysiology happening here? So the pathophysiology is simple. So we told some of the function of the kidney. So whenever the kidney going to affect, or if the kidney getting in a chronic state of damage means, so the kidney function will alter, so that all the function will disturb. So first thing what function we told, waste, it will take a role in the waste removal from the body. So if the kidney function get damaged or diminished means, so whatever the waste material that produce in our body, that will stagnate in our body itself. That is the first thing. Second thing, waste product in the sense, here it includes the urea, uric acids, those are the things also. So if the urea level is getting higher means, that is called the uremia. Some of the nitrogenous waste like uric acid is getting stagnant in your body means, that is called the azotemia. And then some of the waste product, fluid also, we told fluid homeostasis also it is taken role. So if the kidney getting affected means, that fluid also it won't excrete from your body, that will stagnate in your body itself. So these are the things, and then it can lead to some systemic complications like hypertension, and then heart failure. More specifically if you want to tell means, there is a congestive cardiac failure it can develop, anemia, because some kidney will produce some amount of protein, some protein structures like erythropoietin. If that is getting affected means, anemia can occur, electrolyte imbalances also can occur. So this is the eGFR calculation. Commonly with the value of creatinine, we will calculate the eGFR. There are many methods are there. This is the one of the equation, like creatinine clearance. 140 minus age into body weight in kg, 72 into multiplication of serum creatinine in milligram per deciliter. So creatinine clearance for many purpose we will use. Here we are using the purpose of to categorize the people or to staging the CKD people. Mainly to some of the antibiotics based on the creatinine clearance, we will adjust the dose. That is also one of the uses there. But in the case of CKD, to categorize the people, we are using the eGFR rate. Okay. So here we are categorizing people into 5 grades. Grade 5 is a your eGFR or estimated glomerular filtration rate will be less than 15. Normal it is about 90 or more than 90 is a normal. If it is getting less than 50 means, that is the person is very high risk for the CKD, and then the kidney almost stop with working. So grade 4 means you can add plus 14. So thereby 15 to 29, they are very high risk to the CKD, and then the kidney is close to not work. Grade 3 we are dividing into 3A and then 3B. If it is a 3B means 30 to 44, they are very high risk to the CKD, and then 3A means that is 45 to 59, where they are very moderate risk to the CKD. Grade 2 means 60 to 89 of eGFR, that they are moderate risk for that CKD. Grade 1 means eGFR rate will be 19 or more than 90, they are low risk for the CKD. So keep those are the things aside. So this is what mainly as a pre-hospital region we have to remember these other things like clinical manifestations, how we have to assess the people. First thing, urinary system. If you are taking out the history, there you can found the oliguria and then anuria. So in a pre-hospital, what we have to think means, what is the reason for the oliguria and then anuria? Before that, what is mean by oliguria and then anuria? Oliguria means urine output that will be less than 400 ml in a day or per day. So the per day total urine output will be less than 400 ml. What is mean by anuria? Anuria means the urine output will be 0 to 100 ml in a day or per day. Okay, oliguria means less than 400 ml per day. Anuria in the sense 0 to 100 ml per day. Whether that will be a no output or that will be less than 100 ml of urine output per day. So if here we have to think what might be the reason for the reduced urine output. So we know normal urine output it will be somewhat if you are calculating per hour means it will be something like a 60 ml per minute. So by that calculation, if you are 60 ml per hour, okay, 60 ml per hour, 1 ml per minute is a calculation, rough calculation, 1 ml per minute. So if you are taking for 1 hour means 60 ml per hour. If you are calculating per day means somewhat it will come around 1480 or something. So we will roughly calculate as a 1500 ml. 1.5 liter urine output is a normal. But here we are getting in oliguria 1/3 of the thing only we are getting. So remaining 2/3 the body that accumulate in our body. But if you are going into anuria, almost most of the urine or almost most of the waste fluid that is accumulating or that is stagnant in our body itself. Okay, one third here, the whole whole amount of things. So we have to think about the what is the reason for the oliguria and then anuria. First, before that, by seeing the general assessment, by seeing the person itself, we have to categorize the people whether the person is catheterized or not catheterized. Okay, that is the first step what we have to do. Catheterized and then non-catheterized. So some person, they might be prolonged catheterization, they will be in a long time catheterization because of any obstruction or stitches, or because of the CKD history itself, they will be in a Foley's catheterization or suprapubic catheterization. First, in your general assessment, you have to see the whether the person is catheterized or non-catheterized. So we'll see this one later. First, before that, is the common reason for the oliguria and then anuria. There might be a problem in the input. Okay, the first problem might be in the input. Input means the person may take a reduced amount of water, or again it may lead to some of the things like any large amount of hemorrhage can occur, internal bleeding or external bleeding. Those are the things also there. And then the person might be in a dehydration or hemorrhage, or the person might be any history of burns. Okay, these are the means. In a pre-hospital, we have to think about the broadly. So here we are dealing about the CKD, so we should not fix in we should not have a narrow look. We are always have to the broad look, like oliguria anuria means what are the various reasons can occur. That is why I am telling. So first you have to check the input, whether the person in a dehydration or not. How we can check the dehydration? You can check the oral mucosa first, you can check the capillary refill time, you can check the skin turgor, you can check the some cardiac monitor, BP, blood pressure, non-invasive blood pressure, heart rate. Those are the some factors we can identify whether the person in the dehydration or not. And then hemorrhage, you can identify whether internal external hemorrhage is there or not. Burns, in the burns cases also it can occur. So that is regarding the input. Second thing, sometimes the input will be good, means so that your blood supply to the kidney, it will be good, but the problem will be in the kidney itself. So some of the condition we told, nephrosclerosis, glomerulonephritis, those are the things we told, right? So the problem will be in the filtering unit, or the problem will be in the kidney itself. So some of the thing we told, stenosis, so lot of things we told, right? So that is the second reason. Third reason might be in a transport channel. Transport channel. Transport channel means the input will be good, blood supply to the kidney, it will be good, but the problem, there won't be any problem in the kidney. So your kidney also will produce, it will filter everything and then it will produce urine, but the problem will be in a ureter or your urethra, or it will be in a urinary bladder. So these are the some common causes for the oliguria and then anuria. So might be the problem will be in an input area, or the problem will be in a kidney area, or the problem will be in a transport channel like ureter, urethra or urinary bladder. So this also we told some of the condition like obstruction in the urine, some of the malignancies, those are the things also can cause oliguria and then anuria. So already for input we told how we have to assess dehydration, how we can assess, and then hemorrhage, burns also we can assess. So kidney functions here, that might be some of the investigation, in hospital investigation, blood investigation, some of the imaging test we have to go for in the kidney related pathology if we want to identify. Transport channel also, that stone related things also we have to get the person into the definitive care. There we have to go through the some imaging and then some other laboratory values, then only we can identify the whether any problem in that transport channel or not. So these are the some common things for the oliguria and then anuria related. So and then some more category we told whether the person is catheterized and non-catheterized. This is the one of the thing. If the person is catheterized means what are the problem can arise. If the person is having a catheter for the prolonged time means there might be a chance of catheter outflow obstruction. So that also one of the reason, because of any crystal formation or because of any infection that can lead to the urinary catheter obstruction. So for that, at the time we will tackle the condition with we have to give the irrigation of the catheter, irrigation of the bladder, or sometimes we have to change the catheters. Though those are the circumference or circumstances also can occur. Second thing, if the person is catheterized means first check whether the catheter is properly placed or not. Okay, that's the first thing. Second thing, some of the time the catheter can twist. So in the outflow area it can be twist, or it in a tangle, it will be in a twisted manner. So any physical blockage is there or not, that also we have to check. Okay, these are the some catheter related thing always you have to look for. So oliguria, anuria, so we told what are the reasons, how we have to assess. So what it is indicating, oliguria, anuria means we told almost one two-third of the fluid or almost full, the whole fluid waste product is retaining, the body is retaining or it is accumulating in the body. So by that, what it is indicating, what it will leads to, or what are the consequences that will arise means, because of that increased fluid overload, automatically it will affect your organs. It will affect your organs. The in a whole body, the person will develop a anasarca. Okay, that is the first complication. The whole body edema, pitting edema will be there. Second thing, how it will affect your heart. Because of that increased fluid overload, it leads to the congestive cardiac failure. And then third system, how it will affect your respiratory system, it will develop, the person will develop the your pulmonary edema. Okay, because of that pulmonary edema, you can hear the crackle sound, tachypnea, and then Kussmaul's respiration also we can, Kussmaul's respiration is a different part, but anyway we can hear the crackles, and then tachypnea also we can develop in a cardiovascular system. So because of this is the complication of the fluid overload. In a cardiac system, still more complication like a hypertension, pericarditis can occur, coronary artery disease can occur, hypotension, and then arrhythmia is the most common thing. Hypotension, arrhythmia, why it is occurring means, so first one, hypotension, that is because of your acid base disorder, mainly because of the metabolic acidosis. So again here also the acid is a waste product that should be eliminated from your body. But if the kidney function fails means, it will retain more and more acid to your body, thereby it leads to the metabolic acidosis. Finally it leads to the hypotension. So that acid will act on your blood vessel, thereby it will the blood vessel will dilate, thereby it leads to the hypotension, and then it will irritate your myocardium, thereby it leads to the arrhythmias. So those are the some common things. So arrhythmia can occur because of the metabolic acidosis, mean the time because of the hyperkalemia. Okay, these are the reason for the arrhythmias. And then pulmonary system, as like we told, crackles, tachypnea because of the pulmonary edema, Kussmaul's type of respiration, that is because of the metabolic acidosis, uremic pneumonitis. So this is the one of the causes for the ARDS. So you know the regarding the ARDS, acute respiratory distress syndrome. So one of the causes of the ARDS is a uremic pneumonitis. In uremic pneumonitis, it is a rare condition. Anyway, it will affect your wall of your alveoli. It will increase the your it will affect your wall, thereby the easily the permeability will be disturbed. High permeability it will cause, so easily your fluid will reach out your alveoli. Okay, and then gastrointestinal system, mainly anorexia, nausea, vomiting, constipation, peptic ulcer, GI bleeding is one of the common or life threatening emergency what we will encounter. Some of the time it will be in a mild cases. GI bleed means we can manage with a pan or pan infusion. In a pre-hospital you can start pan. If you don't know it is a massive bleeding means, if you have mean that Senk is taken Blakemore tube also we can use. So there and all, in a GA bleed and all, airway protection we have to keep in mind. Hematological wise, the person may get into the anemia, altered immune response, diminished inflammatory response. So these are the things leads to the person in a CKD, they are more prone to the infection. So whenever we are performing like IV cannulation or we are going to intubate the patient means strictly we have to follow the aseptic precautions. Neurological system wise altered mental status, because of the it can lead to the uremic encephalopathy. Because of that the person can develop the altered mental status, seizures, and then coma, muscle twitching, irritability. Electrolyte imbalance wise hyperkalemia will occur. So the hyperkalemia here is the, this is the one of the common more life threat one. So it can leads to the arrhythmia, it can leads to the cardiac arrest, it can leads to the hypotension, those are things. So metabolic acidosis also one of the common thing. Fluid overload, because of that it can leads to the generalized edema and then pulmonary edema. Skin wise pruritus, pallor, hyperpigmentation, itching, and then ecchymosis. So remember these are the how we have to assess, how we have to tackle over that each situation. So whenever we are handling cardiac arrest with the background of CKD means we have to strongly suggest whether that might be because of the hyperkalemia or that might be because of the metabolic acidosis. These are the two major causes for the cardiac arrest in the case of CKD. So whenever you are handling the case of in a pre-hospital mainly I am telling, because if it is in hospital means we will get all resources. So you can take the sample, you can find it, identify what are the causes, those are the things. But in a pre-hospital we won't get that blood sample investigation and all we won't get. Only in hyperkalemia you can relay with your ECG. That is the one reliable factor what we have in a pre-hospital. Another time, so cardiac arrest means just ask the history of the person. If the person have a CKD, so with your consent physician order or advice, you can go through the some soda bicarbonate. Those are the so soda bicarbonate if you are giving means that will manage your hyperkalemia. Mean the same time if the person in the metabolic acidosis also it can manage. So that is one of the thing. Again, if the person, if you want to treat the hyperkalemia means you can go with a GI bolus, or you can give some of the calcium gluconate also recommended. So these are the things. That's why these are the two major reason for the cardiac arrest in CKD. Anyway, still we have to rule out that condition. And then uremic frost also you can see in the case of CKD cases, in advanced CKD. So diagnosis in an in-hospital history collection, physical examination, serum creatinine, urea level, CBC, CRP, ECG, and then serum electrolyte level, urine analysis, imaging wise CT, and then MRI, USG, you can see the sunken kidney. So management, whatever we told in that clinical features we discussed lot, right? That is the what we are going to manage. Some of the additional things in hospital we will manage the anemia. So we'll target the hemoglobin level of 11 to 12 gram per deciliter. Okay. So for that we will give the folic acid. Sometimes we will supplement the erythropoietin itself. In advanced management, some of the people they need a renal replacement therapy like dialysis or hemofiltration or kidney transplant also. So when we are going into dialysis means in a, most importantly in a CKD cases, if any acid base balance or disorder or any electrolyte problem or any fluid overload is there or any uremic symptom like uremic encephalopathy or uremic pneumonitis means we will go with the dialysis. Some of the other indication like if the person get intoxication also we will go with the dialysis. So these are the core management for the CKD. So what are the core management? Means first we will control the, we will target on the blood pressure control. Second we have to think about the erythropoietin supplementation, and then we have to access for the dialysis, nutritional care, and then finally we have to restrict the salt. So in a pre-hospital, remember hyperkalemia management, and then sometimes the person may into the uremic encephalopathy. Those are the features also can occur. Some of the people they went into the arrhythmia. So those are the some common set of management what we have to do in the pre-hospital. So do your best. Shalom.